This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for our Healthy You webinar series. Today's topic is Understanding Binge Eating Disorder, Our Relationship with Food and Body Image. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. Today's presentation is through the members of the Mather Hospital's Partial Hospitalization Program. Let me get up your slides, guys, and then you can get started.
Okay, welcome everyone. Thank you guys for all joining us. My name is David Karp. I'm one of the social workers in the program. I'm also joined today by my coworkers, Pasqua Spinelli, who's a psychiatric mental health nurse practitioner that works with us in the program, Moira Farrell, who's a registered dietitian in our program, and Yamarella Sotero Ramos, who's one of the other social workers and primary therapists in our program. Today, we're going to be going over making food our ally, not our enemy, understanding binge eating disorder and our relationship to food. You can go to the next slide. So on the agenda today, we're going to be focusing on introducing a little bit about our treatment program. We're going to be going over defining binge eating disorder, as well as some other brief overview over other eating disorders, common causes of binge eating disorder, nutrition and binge eating disorder, body image and social media. We're also going to be going over medical complications, medication interventions, possible treatment options, goals of treatment, and outcomes of care. Next slide. In regards to Mather Hospital's eating disorder treatment program, we provide an acute care for people struggling with binge eating disorder, anorexia, and bulimia. We also provide treatment for coexisting psychiatric diagnosis as needed. And we have a wide range of multidisciplinary staff that work with our clients. We treat both adults and adolescents, adolescents ranging from ages 12 to 17, and adults are 18 and up. We provide treatment 5 days a week, and the treatment usually includes individual counseling, nutrition counseling, psychiatric evaluation, and medication management, as well as nutrition counseling as well. Next. In regards to eating disorders, we wanted to define some of the most common eating disorders that people experience and that we work with. Binge eating disorder is characterized by the frequent episodes of uncontrolled eating, during which time an individual experiences a sense of lack of control. We also oftentimes work with anorexia nervosa, which is all oftentimes associated more with restricting, so limiting someone's intake, or oftentimes maybe trying to work through using like excessive weight loss or exercise to manage like their intake. Bulimia nervosa was often characterized by secretive cycles of binging and purging. And then we also sometimes see in the community as well other eating disorders, like other specified feeding and eating disorders, as well as ARFID, which is avoidant restrictive intake disorder. Next. Today, I wanted to go over a couple of myths specifically about binge eating disorders. That's going to be the focus of this presentation. For example, some of the myths that we often see are binge eating and overeating are the same thing. It is important to identify that binge eating and overeating are not always the same thing. When we're discussing binge eating specifically, it's usually referring to people that are struggling with oftentimes a compulsion to eat an excessive amount in a short period of time. This is oftentimes associated with feelings of being out of control, and oftentimes not something that is a part of normalized eating. Many of us, right, sometimes may be experiencing overeating during social events, holidays, enjoying like favorite or enjoyable foods. Binge eating disorder oftentimes is associated with, once again, that compulsion or feeling the need to consume a larger amount of food than what would be normally required in a given day. Binge eating disorder only affects overweight people. We often see with a lot of people in the community many different body sizes of people that are struggling with binge eating disorder. It's not just limited to someone who's just overweight. And this goes for all eating disorders. We'll always say that there's no specific body type for someone struggling with a disorder. It's more focused on the behaviors. Another myth that's very common is dieting or limiting food will stop the binge eating disorder or stop the binge cycle. That is not the case, and that is something we'll go over as part of this presentation. Oftentimes, normalizing eating patterns is the best way to start the process of decreasing and managing binge eating disorder. And the final myth, binge eating disorder can be controlled by willpower. As with all of the eating disorders that we work with, willpower is not always the number one thing that's going to really determine someone's success in treatment. Eating disorders are very complex and oftentimes associated with other co-occurring disorders or other stressors that people are going through. And we'll go over too in terms of willpower. That's not necessarily going to just determine if someone recovers or not from the disorder. Oftentimes treatment, supports, and learning coping skills may be positive ways to manage this disorder. Next slide, please. I know next up, Moira Farrell is going to be going over with us common causes of eating disorders.
Hi, thank you, Dave. Yeah, just to start with, as with other eating disorders, as well as binge eating disorder, there's multi causes. It's not one thing or one reason that can trigger it. So it's usually a combination of 2, 3, or sometimes all of these different factors can play a role. But oftentimes with binge eating disorder, it can happen at a younger age than the other eating disorders would develop, maybe in childhood years. The reason sometimes too is people are using these behaviors for comfort, perhaps. So they learn that, food tastes good, it makes me feel good. So if they're struggling, but usually it's in children that perhaps haven't learned appropriate, tools to express emotions, and maybe in some houses it wasn't something that was supposed to be, talked about. We learn people come to program and they don't talk about their feelings, so they really don't know how or when, how to express it. So sometimes they just know they're feeling bad, and then they begin to, turn to food for comfort. Other, early thing could also be situations where children maybe were neglected, abused, even where there wasn't food available, sometimes maybe for financial reasons, for whatever reasons. So if they've kind of not had food available when they needed it growing up. So sometimes when there is food available, they learn that, well, I don't know what I'm going to eat again, so let me eat a lot and get a lot in. Again, it may not be a conscious thought, but that's kind of how the body responds to a period of under eating and then food available and wind up overeating. Biologically, so over time, somebody perhaps starts out usually for emotional reasons. Other emotional reasons could be somebody, being bullied at school, or having issues or problems or traumas in their life. And it's just, simple and easy to turn to food, whether, depression or anxiety can play a role, especially at a young age. Like I said, bullying could lead to depression and feeling inadequate, and then turning to food for comfort and feeling better, even though it's just temporary in the moment that feels good. But sometimes too, so usually it starts for emotional triggers, using it for comfort, not feeling well, for gratification. And then over time, because people tend to gain weight if they're eating a large amount of food in a short period of time, and they're doing it on a daily basis or every day, they think, well, gosh, I've gained weight from this. Maybe as they go into their teenage years, they're comparing themselves to their friends, people on social media, and say, oh, I don't have a body like these. And then the thought in our society is, well, I got to diet. So then they turn to, restricting, and using those behavior, like not eating enough, skipping meals. And then, so sometimes they get into a situation where they're not eating for a long period of time, and they finally do allow themselves to eat. They may intend to eat a small amount, but then they wind up overeating, and then triggering this binge, because if they have, so biology can take over. So say, sometimes too, say someone had binged at night, sometimes that's a common time to use a binge behavior. And then they wake up in the morning and they're like, oh, I can't believe I ate all that food last night. Well, I'm going to skip breakfast today. I won't eat till later in the day. And then when they finally sit down to eat later in the day, they only intend to eat a small amount, but their biology or their body takes over, and it's like, oh, we haven't eaten in several hours. So let's, the body's telling them. So that's why they get this sense of feeling out of control. They often blame themselves, like it's their cells' fault, but it's really just biology. I haven't eaten in a long period of time. Food is available, and your body is causing you to want to overeat. So sometimes people get in that cycle. They overeat for a period of time, they feel bad about it, then they overeat at their next meal. But certainly people with this continue to use emotional triggers as well. They had a bad day, they had an argument with somebody, they learned that, well, turning to food is a comfort to me, and but then take on top of it that they haven't eaten in a while, they're hungry. So kind of like these two things kind of get enmeshed, biological triggers, psychological triggers, which would be, depression, anxiety, inadequacy, low self-esteem. Certainly also, environmental factors could be sometimes, they've learned in their family of origin that perhaps that they have a parent that's maybe focused on, dieting, having, low calorie foods in the house, maybe, using food punitively, and not, or making comments that, oh, you need to lose weight, you're not going to have dessert tonight, or why don't you go on a diet? The family's like, oh, you should go to, so the family making comments. And sometimes, because as Dave said, it doesn't have anything to do with willpower. Sometimes because of these factors, they feel shame about their eating and their body, and then they can turn to in secrecy eating. Oftentimes people with binge eating disorder will eat in secret. So I think that those, other environmental factors, and certainly major life transitions, we see, what's perhaps traumatic for one person, someone that maybe has appropriate coping tools, has a supportive family, may have had the same experience, the trauma, but they kind of don't want to cope with it. The person with binge eating disorder may have not had those tools, and so then they continue to use like this unhealthy thing, but it can be triggering. So it could be really, as significant as, the loss of a parent, a grandparent. It could be the divorce. It could be even just like moving to a new home from one established area to another. Starting school can trigger the behaviors to become worse. There was any other things I wanted to say. And then genetics. There is some work recently on genetics that research from archives of general psychiatry found that family members of obese individuals with binge eating disorder were twice as likely to suffer the condition as were family members of obese individuals who did not have a history of binge eating disorder. So it can be, so those are kind of like, so it's usually not just one thing, it's a combination of different things, but over time, I think once the kind of the binge eating gets started, the biological and the psychological kind of get enmeshed together. And so we kind of work to kind of tweeze that apart. And if anyone wanted to add anything else, otherwise I can go on to the next slide. All right, next slide. Okay, so now I'm going to talk about nutritional recovery. So I just wanted to kind of, review that when people kind of come to us for treatment, or they're ready to seek treatment from binge eating disorder, they always often have an unhealthy relationship with food. They either love it or they hate it because they feel like they have no control over it. They distrust their body. They feel like their body somehow is betraying them, because when they do eat, they feel like they, can't stop eating. And sometimes they blame it on the food. Like, I shouldn't be eating this type of food. Once I eat it, I can't stop eating it. But in that respect, though, the body's kind of smart, because when we haven't gone, so we may intend to maybe be on a diet, but then we're skipping breakfast. Our body's already hungry, sometimes starving when we sit down to eat. We may intend to eat, well, what this diet plan tells us to eat, but that's not satisfying to someone that hasn't eaten in a while. And then that can trigger, once they start eating, to their body's like, food's available, great, let's come, bring it in. And then they kind of get that sense of feeling out of control. And so they kind of distrust food and their body. Well, I can't eat that kind of food because I'll never stop. And my body doesn't like to stop, so they kind of, so they have a distrust for their, their food and their body. And they also kind of develop maybe a disconnect between what their mind is saying in terms of hunger and fullness. So sometimes they ignore when they feel hungry because they want to lose weight, or they feel bad about the last night's binge, so I'm not going to eat. But so they're ignoring what their body is saying, okay, it's time to eat. And so their mind is saying, no, we're not going to eat now. I don't care if you're hungry, because we have to make up for this. So there's a lot of unhealthiness with the food. And that's kind of one of the things that we do address here in treatment, is to kind of stabilize how this person is eating. Next slide, please. So when they come in, so we call it the term like nutritional recovery. They're coming in here, they're having this unhealthy relationship with food. They don't trust their body. They don't trust food. So we want to, obviously, the first step. So sometimes they can come in with multiple problems. They can have, the eating disorder, the depression, anxiety, other issues. But since that seems to be the main issue right now, since this is what we're addressing, so we want to begin to decrease. And usually with binging, to be diagnosed, if they're recurrent episodes of eating a large amount of food in a short period of time. And often people, when they do have these binge behaviors, they're eating beyond comfort. Like, they want to stop eating, but they can't. And then sometimes they wind up in pain. So again, it's often like they feel like they're out of control with it. I wanted to say something else. I was going to say too, often with binging too, because it can come from like when emotional events happen, someone is binging, but sometimes then when we incorporate the physical part of it, where they're feeling hungry, it can just, usually the binge behaviors become more and more frequent, and oftentimes the quantity of foods that they're binging on could become larger over time, which oftentimes does contribute to gain weight. But like we talked about, we want to stop the compensation for binging. So obviously we don't have magic wands, and somebody comes into treatment, we do eventually begin to decrease the behavior, but oftentimes they want to compensate for that binge, but we have to stop the compensation because that just starts that cycle all over again. So oftentimes people, like it says, dieting behaviors in general, but oftentimes skipping a whole meal to make up for last night's binge. Sometimes people can also develop compensatory behaviors, not just the restricting, but also self-induced vomiting, diet pills, over-exercising, and all different kind of compensatory behaviors. So those are the behaviors that we're addressing and we want to decrease. Next slide. So this is just kind of like what happens oftentimes with the binge eating cycle, is that they binge eat, they feel guilt and shame, it develops food restriction. Food restriction can trigger binging, and sometimes the cycle goes on. So it becomes a behavioral kind of thing. Next slide. So with that said, we need to work to what we call normalized eating patterns, really how the body likes and prefers to eat. So that's like the first step. So, the body likes and prefers to eat about every 4 hours while it's awake. So obviously we go all night, we don't eat anything. So we need to reestablish eating in the morning, regardless if you binged or overate the night before. So the body kind of learns that, yes, food isn't going to be deprived from them anymore. So again, these people have lost sometimes accurate hunger cues, like when their body tells them when they're hungry, they should eat. They may only feel like when they're starving or ravenous. They may not recognize more subtle hunger cues. And sometimes just often eating beyond comfortable fullness, they don't really maybe know what comfortable satisfaction feels like. So we want to kind of do this mechanically in the beginning, reestablish how the body likes and prefers to eat. So we don't really go more than 4 hours. So we kind of do with structured meal plan, planning on having breakfast in the morning. And then, what time is lunch next? Do we need a snack in between? Do we need a meal in between? So whatever, we try not to insert eating behaviors, eating episodes, appropriate for this person's schedule, but also we don't want them to go, the more frequently they eat, the better. So we don't want to take away this ravenous or the starving. And again, this is just from the nutritional standpoint. This isn't, the psychological aspect of it. And, that's because that's another part of it. And that's, the therapists work with them on. So from a nutrition standpoint, we're just working to remove that physical trigger that can cause people to overeat. So we know if they don't eat enough, not eating appropriately. So that's why we're putting this in place. So we talk about, what incorporates a balanced meal, and then plus snacks if they need it. If there's not, say they're going to eat lunch at noon, dinner's not going to be until 7. Well, then we need to have a snack somewhere in there so you're not starving when you sit down to eat dinner. And then obviously, so that's basically what we're doing from the nutritional standpoint. We're using the physical triggers that can cause a binge, waiting too long to eat, also denying and depriving yourself of certain types of foods, because we all like the way certain foods taste rather, and we may not be eating a food for the nutritional value, but we like the way it tastes. And so sometimes that can trigger somebody if they're constantly denying or depriving themselves of a certain type of food. Then when they wind up eating it, they always overeat it because it may not be a conscious thought, but the body's like, oh, we're going to get to eat this again, so let's eat a whole bunch of it right now. And so that's why they distrust certain types of food. But in working with them, we learn to reincorporate those types of foods back in. So it's really not the food's fault. Next slide. So this is kind of like when we talk about, balanced meals. Obviously, we're tailoring it to individual needs, but we want to make sure that at minimum, and we're having balanced meals that incorporate some type of carbohydrates, our starches, our bread, rice, cereal, pasta, some type of protein or a dairy source, dietary fat, a plant source, whether it be a fruit or a vegetable. Those are the core things. Certainly, you can have both a fruit and a vegetable, or you can drink a cup of milk with the chicken sandwich. But the bottom line is, at minimum, we want to incorporate those things. And sometimes stepping out of the box, we want to learn that, it's okay to incorporate. Now, you have dessert down there, but maybe we could even change it to pleasurable food, whatever that is in the moment. So sometimes incorporating those types of foods that we only eat for pleasure, maybe with a meal, like maybe a bag of potato chips at lunch, 4 cookies with a sandwich at lunch as dessert, or something like that, to begin to incorporate it back in normal portions, rather than when you're starving, you open a bag of potato chips and eat the whole thing at once. So we do talk about that. And then also, if people enjoy to drink a caloric beverage, that, again, we talk about, sticking within portion size, which is generally a cup of most drinks or a half a cup of juice. So that's kind of what meals are going to look like. And then we're going to do that, structured at least 3 times a day, and then snacking in the middle if we need it. And snacking too, when we talk about, like, maybe we're going to incorporate these pleasurable foods with their meal. So snacking could be, banana and peanut butter, yogurt and fruit. It doesn't have to be, chips or cookies or whatever. So that's what we mean by, with snacking in between. Next slide, please. So basically, we tailor their meal plan to meet their nutritional needs. So they're getting in all the foods that they need. And in some cases, believe it or not, even maybe people are binge eating and they become overweight from it, they still may be nutritionally depleted because they're not getting in all the foods that they need, or the food groups or the nutrients and stuff. So we want to make sure they're eating an adequate amount. So we talked about, like, this hunger and fullness cue. So when we feel hunger, that's our body telling us it's time to refuel. So we use a hunger and fullness scale. So it kind of goes from 0 is ravenous, and it goes on a continuum till 10, which is stuffed and uncomfortable. So it helps them to kind of rate like, okay, well, where am I when I feel like I'm ready to have a meal? Usually we say that's around 3. So sometimes people with binge eating may only ever start when they're 0 or 1. So we want to learn to start eating when you're ready for a meal. And then also, what does comfortable, content, fullness feel like? And that's somewhere on the continuum. So we have them use that when they eat so they can become more aware of what their body cues are telling them, and then they become stronger. So obviously by eating more regularly, we're decreasing these physical urges that people can get from overeating or binging. And then it also helps to normalize the metabolism. Usually metabolism is slow. People are, sometimes they're, been yo-yo dieting, weight cycling, and their metabolism doesn't know what's going on. So by being consistent with eating, it helps your metabolism to normalize. So again, like I said, these are helping. So once kind of sometimes we begin to decrease the physical triggers, the binges aren't happening as often. And when they do happen, it's usually for, maybe an emotional eating or a psychological reason. So they work with their therapist to kind of figure out, well, why is that event happening? And what other tools can I use to replace, like when I'm using food? But if they're still being restrictive with their eating, it's still entangled, and we can't tell the difference if it was an emotional binge, was it a physical binge. And that's one of the things that we work on. We want to eliminate those physical triggers. Next slide. This is a slide I came out a little bit blurry, but I like to use it. It was from a webinar that I went to from this, it's a residential treatment program. But she kind of compared like, nutrition recovery, they call it rehabilitation, how it's kind of similar to physical therapy, because I don't know if anyone's had a therapy, but usually they want the physical therapist or the doctors want you getting up, moving those parts right away. If you had like a, like a knee replacement, they want you to stand up and start walking the next day. And that just seems ridiculous. So sometimes when people come in to us, you're like, you want me to eat all that food in a day? Well, that's ridiculous. I need to lose weight. So it's kind of like the same thing. So, so the second one just says it hurts to move and it goes against all your instincts. That is, what the thought process is too. Like, it goes against all my instincts. You're telling me, this is what I need to do. Well, that doesn't make any sense. But certainly as, we have the meal plan and we move along the journey, they get, just like with physical rehabilitation, they get support from the physical therapist. Well, here they get support from therapists, nutritionists, nurse practitioners. So they get a lot of support here. Certainly we begin to progress to the same way with exercises. We work to kind of maybe liberalize maybe how they're eating, maybe not as structured, maybe going off listening to your hunger and fullness cues. I mean, certainly that's the long-term goal. We don't want to have to follow a structured meal plan, but so becoming, more individualized, or being able to, listen to your body. I think this last part, assume you don't need it anymore when you see progress. So some risk greater. So sometimes people they feel like, oh, I got this, I'm done, I don't need to be here anymore, I'm not going to follow therapy. But then the same thing that says your risk re-entry. I don't know, I just like that slide. So that's kind of like what we're doing here. Next slide. And then the last thing that just to talk about is that, so what helps too, so we have the structured meal plan. Let's see how you're doing. So we do have them keep a food journal, but it's a thoughts and feelings food journal. It's not a punitive one. Write down the calories, write down the grams of this, that, and the other thing. Just really, did you have a balanced meal at breakfast? I have the hunger and fullness scale on it. So they're rating when they started eating, how hungry they felt, when they were done, how full they can be. Certainly, we monitor weight, we monitor how they're eating. We may need to adjust the meal plan at some point, maybe decrease it, maybe increase it. Maybe I'd look, oh, you know what, you are eating, but maybe, you're missing some protein here this day. Maybe we need to add more protein at lunch or whatever. So, it helps me to see day to day what people are doing and how we can make some adjustments to keep them on track with normalized eating. And certainly it's a way too, because it's a thoughts and feelings food journal. We can say, oh, it looks like you had a binge this morning, but then your mood was like really bad when you woke up. So maybe that was like an emotional response. Or it looks like, well, you skipped breakfast this day and you only had a snack as lunch, then you triggered at night. and you binge that night, well, maybe that the trigger for that was that you didn't eat enough during the day. So we can kind of, use that to help people along to kind of figure out, what's happening. And I think that's the last slide. Can you go to the next one and I'll figure out who's talking next? Who is Yami? Are you going to do that?
It's going to be over to me.
Dave is going to come
Yep.
back to Dave. Okay. Dave, we'll send it back to you.
Thank you. So next, we felt it would be important to kind of tie in after talking about kind of how people are struggling oftentimes with their relationship with food, to also talk about how body image and our relationship with our body and how we view our bodies oftentimes play an important role in recovery and treatment for eating disorders. Specifically when it comes to binge eating disorders, especially, there oftentimes is a preoccupation or a lot of focus, like Moira discussed, in terms of a desire to either diet or lose weight. And oftentimes when it comes to that preoccupation, it's very challenging for people to have motivation to make changes that we're asking them to make in treatment, because they're afraid oftentimes that their body is going to change in a way that they're viewing as negative. Oftentimes we see in a lot of eating disorder clients as well, they're struggling with body dysmorphia or disturbance in their body image. When we're talking about body dysmorphia specifically, we're talking about individuals who are picking out many negatives and very preoccupied with picking out negative things about them, so their bodies and their physical appearance. When it comes to the disturbance in body image, oftentimes we're referring to the distress that their body image causes them. Many times, like when Moira discussed with that cycle of people engaging in binge eating behaviors, leading to guilt or shame, oftentimes when we're working in therapy and more from the psychological perspective and approach, we're oftentimes focusing on what those feelings of guilt and shame are, how to cope and manage with those emotions, and also too sometimes identifying how their relationship with their body image is really negatively impacting their functioning and ability to have motivation to make these changes. Additionally, with body image, we are seeing, especially when it comes to social media, as well as with media in general, a major focus on things like weight loss, dieting, also even things I know like more recently we've discussed within the treatment team, like medications on the market that are being focused or promoted as ways to manage weight, which oftentimes we see with our eating disorder population, people are very prone or susceptible to then become more preoccupied with weight loss. And that's something that we tend to work with our clients on, managing ways to normalize kind of their view of their bodies, being able to accept parts of their bodies that maybe they're identifying as specifically negative, as well as to kind of talking about oftentimes and having open conversations about how society oftentimes negatively impacts our expectations of what we should look like. And that is a major part of recovery, is coming to terms and acceptance of the way our bodies are in the moment. Next slide, please. These are some body image statistics that I had gotten together that I thought were just a good reflection of kind of how many people are struggling with body image, starting, like Moira said, when it comes to the causes of eating disorders at a very young age. Oftentimes we're seeing, for instance, like body image concerns like in like girls as young as even at 6, and having expressing concerns about their own weight or shape. And 40 to 60% of elementary school girls ages 6 to 12 are concerned about their weight or about becoming too fat. The focus on weight within especially the adolescent population, certainly when it comes to social media, things like TikTok, Snapchat filters or Instagram, oftentimes understanding too within like how society is right now structured with that social media, how many of the images that we do see online are not accurate depictions of reality, is often very difficult for someone struggling with body image issues, or specifically with eating disorders such as binge eating disorder, to understand or be able to accurately perceive or stop comparing themselves to those other individuals. Next slide, please. In terms of changing negative body image, we often discuss with our clients that body image is one of the last things oftentimes to change when it comes to eating disorder recovery. Oftentimes people have to go through a significant period of time of managing their behaviors, decreasing how often they're engaging in their eating disorder, as well as learning more positive coping skills to then shift the focus away from that preoccupation with their body. Oftentimes changing like our negative body image is a way of kind of giving up that sense of control. Oftentimes with eating disorders, body image or trying to change the way we appear can oftentimes feel like a sense of control. And so when someone's giving up their eating disorder and not engaging with it anymore, oftentimes we see that they need to replace it with other, once again, more healthy coping skills, or also reaching out for support, validation from others. And I know these are some of the things that I have listed here on this slide that we often encourage people to start focusing on. I think some really important ones I know is, like I had mentioned, social media. So being very mindful of what social media we're consuming, as well as maybe putting limits or unfollowing certain accounts, especially in our adolescent population. This is often discussed with them. We also talk with a lot of our clients about like covering, like removing or decorating mirrors that are in like common places where someone may engage in behavior such as body checking, or like a compulsive or preoccupation behavior where someone's really checking their body repeatedly throughout the day. We also encourage people to make sure, like when trying on clothing, things like that, like we often encourage a lot of our clients as well to instead, like rather than checking in the mirror, instead like trying on the clothing, asking ourselves, does this feel comfortable? And oftentimes like allowing ourselves to accept that like I know one of my favorite sayings would be like, the clothes are supposed to fit us, we're not supposed to fit the clothing. I think when it comes down to changing our negative body image, we oftentimes focus on kind of neutralizing the negative statements that people often are experiencing about their bodies and focusing more on neutral or positive statements that they can make about how their body helps them function. What are some strengths that their bodies like provide for them? What are things that they are successful with in their life, ways that they're competent in their life? And focusing on other, once again, like more positive, healthy coping skills to manage the distress that they're feeling regarding their bodies. I believe the next slide is going to be moved over to Pasqua Spinelli, who's going to be talking about medication and eating disorders.
Hi, my name is Pasqua Spinelli, and as you could see, I work with a great team. They are the elite of the eating disorders here in New York and probably throughout the country. So my role is of medication management and psychiatric evaluations, in addition to everything our team does: nutrition, social work, family, and individual counseling. And as health practitioners, we're monitoring vital signs, their physical status, their height and weight, cardiovascular functioning, and looking for certain signs for diabetes and high cholesterol and hypertension. And we also look for other signs if patients have calluses on their knuckles. Also, any issues with dental erosion, which could be a sign of vomiting with certain eating disorders. If their glands are enlarged, or if they have hemorrhage, sometimes we'll see right in their eyes some red specks. Or also, something that we commonly see in all our eating disorder patients is self-mutilation and cutting. Next slide. So binge eating disorder is more prevalent in females with a rate of 2.6% and a 3-to-1 ratio with females to males. And it's more common. We've seen it in high school and college students with a median age of 23. And we see it in all racial, economic, and also different cultures. The clinical presentation for binge eating disorder was discussed before, but we see weight gain, fluctuation in weight, bloating, lethargy, again with the glands, enlargement, guilt, depression, and anxiety. There's such a big workup with everyone on this team. Physical, mental, and psychosocial evaluations, nutritional intake and assessments. And one of my roles is also to do lab work and to follow up with different labs. And if you see on the slide, these are just common labs that we would order. Also, in addition to what you see on the slide, someone who uses excessive laxatives will see changes in their magnesium levels and phosphorus levels. We work closely with their medical doctors or cardiologists, so we're in constant discussion and getting collateral information from different professionals on the team and outside the team. Next. Common medications that we use in our adolescent population is Prozac, Celexa, or Zoloft. In adults, sometimes Tegretol and Topamax is used, and tricyclic antidepressants. There's a warning with the tricyclic antidepressants with cardiac malfunction, so we're very cautious about using it. Next. Antidepressants, specifically Prozac in the adolescent population, is FDA approved for anxiety, anorexia, bulimia, depression, and OCD. Next. And we work closely with the family, discussing the risk, the benefits. We also are constantly in touch with the medical professionals on the team on the outside about any side effects that may be occurring. One of the common medications that is heavily studied is Prozac. And on this slide, you see many different side effects. We always let the parents and the families know and the patients that some of these side effects are temporary and they will go away in time. Next. Again, these are patient education for the family. We go over certain warnings or adverse reactions that we would like the parents to call us so we could determine if we need to discontinue the medication. Many of these patients are on different medications with their medical providers, either birth control or hormones, or other medications, antibiotics. So sometimes it affects the effectiveness and the metabolism of our medication. So it's important that we have an open line of communication, not only with the family and the patient, but the collateral doctors on the outside. Next. And next, Yami.
Hi, everyone. I'm Yam Morales, like Dave said in the beginning. I'm one of the primary therapists here that works directly with the patients as well as families. So let's discuss some treatment options. So the good thing is that we've been discussing the symptoms, the causes, but we also want to make sure that we understand that the good news is that there are treatment options, not only nutritional, counseling and nutrition rehabilitation, but also psychological treatment. So the level of care is going to basically be determined by how severe the symptoms are and how the lack of functioning has been affected. So we can, if we look at the slide, we can go from least invasive to more invasive. So the first level of care would be outpatient. So there are outpatient psychiatrists, nutritionists, therapists, and primary care physicians that are informed in eating disorders and can provide the care outpatient. So outpatient, we see people that might be showing some symptoms of eating disorders, however, are able to manage it and function, go to school, go to work, work on their relationships, work on their motivation, and restore that relationship with food and with their bodies. If we see that outpatient is not working out so well, meaning we see a lack in functioning, people can't remain at work, or have trouble with attending school, concentrating in school, that's when we go to the second level of care, which is partial hospitalization / intensive outpatient. So partial hospitalization is a full day program. That's where we provide treatment at. And then we also have intensive outpatient programs, which is more like a half-day program. So it's less hours in the day, but people are getting treatment. I mean, we see intensive outpatient being 5 days a week for 3 hours generally, and partial hospitalization for about 6 hours, 5 days a week. Again, in this sense, we see that lack of functioning. There's this intense preoccupation, a lot of anxiety around food. And again, it can be tied with the biological aspect of it, and that, years of someone having this unhealthy relationship with food, of that binging restricting cycle that Maura was discussing earlier. But we can also see how there are the psychological aspects of it. So, sometimes we see trauma, neglect, feeling like there's a lot of chaos around. So using food as a way to control. And then we can go even more intensive. And if partial hospitalization or intensive outpatient programs are not working, that might mean, so by not working, I mean people can be in partial hospitalization for a number of weeks and the symptoms are still there. Restriction is still there, the binging is still there, that it's not enough support for someone to improve their functioning, then we might look into a residential treatment. So basically here, someone would be in treatment 24/7. And it would encompass the all practices, or psychiatry, nutrition, therapy, and coordination with primary care physicians. But this would be more of a 24/7 therapeutic environment. And then if we, eating disorders do take a toll medically, right, physically. So we do see how for some people, their eating disorder behaviors, meaning the restriction, the binging, the use of laxatives, induced vomiting, will cause complications medically. So at this point, we talk about this patient might need a medical hospitalization, or even we see how there are inpatient units that are specialized in eating disorders. So again, the good thing is that no matter what your symptoms are, there are options for care, and you can find a lot of these levels of care covered by your insurance. So it's just a matter of informing yourselves and just asking for support and guidance on where to find the provider. I feel like I might be struggling. I'm preoccupied with my body. I feel like I'm thinking about food all the time. It feels torturous. Just using some of the language that our patients use. I feel like I need help. So, that's part of why we're here, kind of informing the community, and also just us understanding that there are different options for treatment. So you don't have to do it alone, nor should you have to do it alone. So let's move on to treatment modalities, right? So therapy-wise, what do we do in sessions? So there is a number of evidence-based practice treatment modalities or models that have been studied and really researched when it comes to eating disorders and their effectiveness with treating eating disorders, and that is cognitive behavioral therapy. So in cognitive behavioral therapy, we study just briefly a connection between thoughts, emotions, and actions, right? So how our emotions affect our actions, right? If I don't feel it, I don't do it. So kind of focusing on that cycle, we do different skills and exercises to just get someone to be able to understand where their behavior comes from and how not only our emotions affect our behaviors, but it goes both ways. So we can understand how changing our behavior can also change the way that I do things, or not do things, feel, right? So shifting our emotions based on what we do. Dialectical behavioral therapy is also something that has been studied, and the effectiveness of treating eating disorders. And this one focuses more on challenging that black and white thinking that a lot of people struggle with when they are going or experiencing an eating disorder. So like with Moira was saying earlier, that idea of I binged last night, so that means that I have to restrict the next day, right? So that's an example of black and white thinking, or all or nothing. And dialectical behavioral therapy doesn't only help us understand the dialectic or the middle ground, but also gives us practical skills on how to challenge that pattern of thinking and cope with the emotions that come with changing our behavior. We also have acceptance and commitment therapy that is also really helpful. This one basically helps people change that behavior, and in changing the behavior, then accepting the process and just committing to it, and then long term we can see an improvement in their symptoms. And also family-based therapy treatment. So this one is more utilized in the adolescent population. And it's basically, in simple words, a type of treatment where the family is fully involved in their treatment. So the idea is that the patient or the adolescent surrenders all control, right? Eating disorders is all about control. I don't want to let go of my dieting behaviors. I don't want to let go. I don't want to surrender myself to following this meal plan. So the idea is that the patient lets go of that, and the family then comes in, and the family is picking out their meals, obviously coordinating and having conversation with the nutritionist, but the family is preparing meals, serving meals, and then the kid, right, or the adolescent can then focus more on how does this make me feel, right? How does surrendering your control to treatment feels, and what does that trigger for you, and kind of having that conversation discussion around the emotions and what you're going through. It also, we see a lot of the time where even though they might not acknowledge it, there can be a point in time where they're like relieved because they don't have to think about food. So in the process, they'll realize how, even though it might have not been so comfortable to have my parents take full control of my treatment, it's what I needed. And family-based therapy is done in levels or sequences where we go, from parents having full control to transitioning the adolescent, or the adolescent to just have more of an independence with it, right? So ultimately, treatment is meant to, especially when we see the more restrictive kind of treatment, where if we see like an inpatient where they have no say, their medical status is at risk, So they have to be able to follow a meal plan. A lot of the times they're tube fed, to residential where it's 24/7. So the point of treatment is if you're struggling and you're not functioning right, you in the beginning stages of it, trusting treatment because you have less say, meaning less control, right? So, but then transitioning you to a point where, how Maura was saying earlier as well, and I think David also spoke on it, you have more of a, let's tap into our hunger cues. Let's not follow this like rigid meal plan. So again, it's not all black and white. There is a transition to more independence in our own recovery. Next slide, please. All right, and so then briefly, just the goals of treatment are going to depend on the level of care, right? And I kind of did speak on this already, but outpatient, it's more of so like overcoming life challenges, right? So a lot of our symptoms, because they are connected or associated with life challenges, life circumstances. Can I manage those and cope with those with the help of outpatient providers? Or do I need to move to the next level where I need to maybe gain more insight, gain coping skills, understand how can I cope with this in a more healthier way? We see more acute symptoms. So again, symptoms that affect the functioning. So partial hospitalization, intensive outpatient, the goal is to increase that functioning. They're still in the community, right? So they come here during the day, they go home. If you're an intensive outpatient, you're going to work in the morning, coming here in the afternoon. If you're an adolescent, you're going to school in the morning, coming here in the afternoon. So we're still in the community, still interacting, still kind of exposed to life challenges, a little bit more restrictive in the interaction that I have with the community. So that would be the goals of partial as well as intensive outpatient. And then if we move on to residential treatment, this is more, we see that difficulty with restoring weight or normalizing that eating, depending on what it is. So we see a combination of stabilization of symptoms of eating disorder symptoms, eating disorder behaviors, as well as closely monitoring any medical conditions. And then inpatient hospitalization, this is fully focused on treating, or the goal is to understand what the medical complications are, as well as treating them. So we see different consult with not only psych, but also gastroenterology, cardiology, and it's more because obviously, like Pascal was mentioning, at the partial level of care, we also coordinate with medical professionals, but in the inpatient setting is more, we're treating that there's more concern of medical complications. Next slide, please. And just some outcomes. These are some statistics from the NEDA website, which is the National Eating Disorder Association. They have really good resources on there, not only for treatment, but also understanding how our communities are affected by eating disorders. Disordered eating is normalized in society nowadays, especially with the diet culture that is out there and being flooded in social media. So understanding that that eating disorders are a mental illness, and they look different for different people, they still affect the same way. So just to look into a little bit, 28.4% of people with current binge eating disorder are receiving treatment for their disorder. 43.6% of people with binge eating disorder at some point in their lives will receive treatment. So that's, in both, we see more than 50% of people that are not even receiving treatment for binge eating disorder. There's a lot of stigma around binge eating disorder. There's a lot of myths and misconceptions about binge eating disorder. How Dave was saying earlier, someone can be diagnosed with binge eating disorder and it doesn't matter what body type they have. Someone can be diagnosed anorexic, and there's a misconception of what anorexia looks like because there's no looks to anorexia. It has nothing to do with your body type. It has everything to do with your mental struggles and psychological and behavior with food. About 20% of people with eating disorders die. So eating disorders are serious conditions. With treatment, this number decreases by 2 to 3%, and about 60% of people with eating disorders recover. So recovery is possible, but we need to be able to access resources and support and understand that eating disorders are a mental illness and as serious as any mental illness that we see and talk about. And again, I think one of the main barriers is that normalization of disordered eating and all the diet culture and the misconceptions of what eating disorders are or look like. And I think that is it for us. So any questions? I know we kind of ran over a little bit, but we want to make sure that we're answering questions and providing, just information to everybody that's watching.
I think we had one question that's on the chat. The question was, is ARFID treated? I know when it comes to our specific program here at Mather for the partial and IOP, oftentimes it depends on what symptoms the client's struggling with when it comes with ARFID. Also, too, depends on how well they may respond to like a group. We're very group heavy in terms of like throughout the day. They're in a lot of group settings and group meals. Some clients I know we've had that have struggled with ARFID symptoms that we have worked with over the years. However, oftentimes we are looking for sometimes alternative treatment options that may be more specialized or focused in the treatment of ARFID. For instance, Yami mentioned family-based therapy. That's been shown, especially in children and adolescent, can oftentimes be a more effective setting and treatment setting because it's more individualized to that specific person, due to ARFID being more about fears regarding becoming sick or ill or certain textures, tastes, things like that. It's a wider variety of symptoms that they may be struggling with that we might not be able to focus as specifically on while they're here with us.
All right, so it looks like that was the only question we received. So I just wanted to thank you all for your presentation today. If you have any additional questions, you can email them to matherhospital@northwell.edu.
I see another question
Oh,
popped up.
yes, another one. Let's see.
Just a thank you.
Oh, perfect.
I-
Once you exit the webinar, you'll, oh, wait, hold on. We're getting more questions here.
All right. Well, the third was about, there are 12-step programs. One of them is called EDA, which stands for Eating Disorder Associates. They have them live in person, but they also have a community on online. If you go to, it's EDA or Eating Disorder Recovery Anonymous. OAs, some people certainly have had success going to OA. It all depends. Gray sheets for somebody with binge eating disorder really is contraindicated. A gray sheet just talks about what foods you should eat, what you should avoid, right here, what in the first stages of this treatment, because restricting food intake, especially foods that we like, are going to trigger binge episodes. So we definitely don't want people to go to OA meetings where they have gray sheets or somebody is telling them what they should or shouldn't eat. Certainly if somebody wants to go to OA, and also too, because you have to give up something. Certainly just giving up an eating disorder, I want to give up binging. It shouldn't have to be I'm giving up all these foods that I enjoy eating, because that's not really going to help. Is there another program to Brooklyn or Manhattan via Mather?
I know depending on treatment options, certainly if you have specific questions like what other treatment programs are available based on like it's going to vary based on insurance. I would be happy to answer any questions. I know Jonathan had mentioned about emailing to send any questions to that email address. He can help get you connected to me, and I can go over more specific locations that may exist in the community, because I may need to go over what insurance you have and what benefits that might cover.
All right, we'll give it a few seconds here to see if
Sure.
anybody has any more questions.
I know part of that question that Moira answered as well. I know someone was asking, is eating disorder a spiritual disease? I'm not sure specifically what you mean by a spiritual disease. I know when it comes to mental health, mental illness specifically, we always approach it that it's coming more from biological and genetic issue, like that these we are basing off of, right, that eating disorders are biologically founded, and then our mental health is really based in chemical imbalances and how our brains are functioning. Eating disorders also too oftentimes are more about coping or trying to manage and find a sense of control, like Yami was talking about, within our lives. It's not necessarily something that's we try to really focus, especially like in DBT therapy, the dialectical behavior therapy, away from judgmental statements or viewing any of the behaviors or symptoms that someone may be struggling from a morality. So not bringing it into a question of morality, rather into, right, what's healthy, what's not healthy for me, what's more adaptive, what's a more positive way for me to cope with these symptoms, rather than engaging in behaviors that may be, damaging or harmful to our physical health, well-being, and mental state.
Yeah, and David, I wanted to answer Kevin's question also. Kevin, I do lots of volunteer work in different houses of worship, and some faiths do see it as a spiritual disease, like that they're not close to God or Allah, that they're not a good person. And those are all myths. Actually, the houses of worship do support mental health and support medication if needed.
All right, so I think that was the last question. I just wanted to thank you all again for presenting. Once the webinar concludes, you'll see a brief survey. If you can complete that survey, that helps us plan future programs. And if you'd like to view past Healthy You webinars, you can visit them at www.matherhospital.org/healthyu. I just wanted to thank you all again, and have a great day.
Thanks.
Thank you.
Right, thanks.